Welcome back everyone. In this lesson I will discuss about congenital adrenal hyperplasia, especially the most common one, that is about 21 hydroxylase deficiency. To start from the basics, adrenal gland is composed of two endocrine tissues, that is medulla and the cortex. Medulla secretes epinephrine and then norepinephrine, and the cortex has three zones: zona glomerulosa, which secretes or which synthesizes aldosterone; zona fasciculata, which secretes cortisol and adrenal androgens; and the zona reticularis, which produce adrenal androgens. Adrenal steroids or glucocorticoids increase glucose production, increase fatty acid level, increase proteolysis. They are necessary for normal growth and development. They inhibit fibroblasts, inhibit osteoblasts and osteoclastic activity. They have positive nootropic effect and they regulate immune system. From mineralocorticoids, the most common and the most important one is aldosterone. Aldosterone maintains intravascular volume by eliminating potassium and hydrogen and conserving sodium. The principal site of action of aldosterone is as distal nephron, and it's regulated by the renin-angiotensin system and the potassium level. The third adrenal steroid is androgen. There are two types, dihydropindasterone and the dihydropindasterone sulfate. Their actions are exercised through conversion to testosterone and the dihydrotestosterone. And in women, 50% of androgens are derived from adrenal glands, whereas in men, only less than 2% of androgens are derived from adrenal glands. When we see adrenal hormonal synthesis, the basic material that is needed for adrenal hormone synthesis is cholesterol. From cholesterol, different pathways and the different enzymes are involved to give aldosterone, cortisol, and the dihydrotestosterone, as you see on the image. Congenital adrenal hyperplasia is a family of autosomal recessive disorder of cortisol biosynthesis, and cortisol deficiency increases secretion of corticotropin or adrenocorticotropic hormone, which in turn leads to adrenocortical hyperplasia and overproduction of intermediate metabolites. Incomplete viralization or precocious puberty in affected males and viralization or sexual infantilism in affected males. So, if males are affected, it causes incomplete viralization or precocious puberty, whereas in affected females, it causes viralization or sexual infantilism. When we see different types of congenital adrenal hyperplasia, the most common one or the most common type is 21 hydroxylase deficiency, which is responsible for more than 90% of congenital adrenal hyperplasia. It is classified into salt-losing, simple viralizing, and non-classic type. The other is 11-beta hydroxylase deficiency. The other is 3-beta hydroxysteroid dehydrogenase deficiency, and the other is 70 hydroxylase deficiency. There is also reported adrenal hyperplasia, which accounts for less than 1% of congenital adrenal hyperplasia. When we see the most common cause of congenital adrenal hyperplasia, or CH caused by 21 hydroxylase deficiency, this is responsible for more than 90% of CH cases, which are caused by 21 hydroxylase deficiency, and it occurs 1 in 50 to 20,000 births. There are two common presenting forms, the classic and the non-classic type. In classic type, 70% of affected infants have the salt-losing form, in which there is no enzyme activity at all, whereas 30% have the simple viralizing form, those that have low but detectable enzyme activity, 1 to 2%. The non-classic disease has a prevalence of approximately 1 in 1,000, and they have 20 to 60% of normal enzymatic activity. So the degree of effect of those deficiencies based on the amount or the percentage of the enzymatic activity that's available. When we see 21 hydroxylase deficiency, in this case, progesterone is not converted to dihydrocorticosterone, and 70-hydroxyprogesterone is not converted to 11-deoxycortisol, which is required for production of aldosterone and cortisol. So progesterone and the 70-hydroxyprogesterones are increased in amount, whereas deoxycorticosterone and the 11-deoxycortisol is decreased. This progesterone and the 70-hydroxyprogesterone is shunted to the androstenedione, which is adrenal steroids. This enzyme hydroxylates progesterone and the 7-hydroxyprogesterone to yield 11-deoxycortisol and 11-deoxycortisol respectively, as I have said above. And this conversion are required for synthesis of aldosterone and cortisol respectively. Both hormones are deficient in the most severe salt-wasting form of the disease. When we see the clinical manifestation of 2,1-hydroxylase deficiency, females with the classic form or salt-losing and non-salt-losing presents with genital ambiguity. Males with the salt-losing form presents with failure to thrive, dehydration, hyponatremia, hyperkalemia, typically at 7 to 14 days of life. Males with the classic non-salt-losing form typically present at 2 to 4 years of age with early viralization, such as development of pubic hair, growth spurt, adult body odor, and the like. Non-classic 21-hydroxylase deficiency may present as hirsutism, menstrual irregularity, early puberty, sexual precocity, or there may be no symptoms at all in females. Prenatal exposure of the brain to high levels of androgens might influence subsequent sexual dimorphic behaviors in affected females. So, girls might demonstrate aggressive play behavior. Women may have decreased interest in maternal roles. There is an increased frequency of homosexuality in affected females. Untreated or inadequately treated children of both genders develop additional signs of androgen excess after birth, and the causes: rapid somatic growth and accelerated skeletal maturation, muscular development, which might be excessive, pubic and axillary hair appearance and acne, and also deep voice develops early in life. Similarly, but usually milder signs of androgen excess occur in non-classic 2,1-hydroxylase deficiency. In this attenuated form, cortisol and aldosterone levels are normal, and affected females have normal genitals at birth. Males and females may present with precocious puberty and early development of pubic and axillary hair. Hirsutism, acne, menstrual disorders, infertility may develop later in life, but many females and males are completely asymptomatic. Development of the adrenal medulla requires exposure to the high cortisol levels normally present within the adrenal gland. These patients with classic congenital adrenal hyperplasia have abnormal adrenomedullary function as evidenced by blunt epinephrine response, decreased blood glucose level, and low heart rates with exercise. Adrenomedullary dysfunction may exacerbate the cardiovascular effects of cortisol deficiency in untreated or undertreated patients. When we see the salt-losing form, this enzymatic deficiency is more severe or even complete, so secretions of cortisol may be very slow. In addition, the adrenal cortex cannot secrete sufficient aldosterone and result in acute adrenal or salt-losing crisis. There is maximal activity of the CRH and adrenocorticotropic hormone axis, inducing maximal secretion of adrenal androgen and a near total masculinization of the external genitalia in females. In females, especially in female infants, attention is attracted first to the markedly ambiguous genitalia. The masculinization might be so extreme that there is complete fusion of labia and the formation of penile urethra. In such cases, the external genitalia are those of normal male except that no gonads are descended. The total or almost complete absence of cortisol and aldosterone secretion results in an acute adrenal crisis, usually between the 7th to 15th day of life. The infants feed poorly, have vomiting, and lose a significant amount of weight from dehydration during adrenal crisis. The serum electrolytes show an increase in serum potassium or hyperkalemia and fall in sodium or hyponatremia. The acute adrenal crisis readily develops into cardiovascular collapse, cardiac arrest, and even death. When we see some signs of acute adrenal crisis, decreased activity, altered mental status, pure feeding, vomiting, dry tongue, buccal mucosa, hypotension, dehydration, hyperpigmentation, hypoglycemia, electrolyte disturbance such as hyponatremia and hyperkalemia, metabolic acidosis, and the lack of weight gain. Regarding laboratory workup for congenital adrenal hyperplasia, prenatal diagnosis is possible, and prenatal diagnosis of 21-hydroxylase is possible late in the first trimester by analysis of DNA obtained by chorionic villus sampling or during the second trimester by amniocentesis. During newborn screening, in a setup where such facilities are available, 21-hydroxylase deficiency is often undiagnosed in affected males until they have severe adrenal insufficiency. So, the programs analyze 70-hydroprogesterone levels because males are normal until they develop adrenal crisis. So, it is better to detect early before they develop adrenal crisis by doing 70-hydroxyprogesterone level. Karyotyping, CYP21 level, serum cortisol and aldosterone, cortisol precursors which is expected to increase such as hydroxyprogesterone before and after ACTH stimulation, ACTH level which is expected to be high, blood glucose level, serum electrolytes, we expect hyponatremia and hyperkalemia, plasma renal activity, adrenal androgens, and avoiding cystoid retrogram should be done. When we see treatment of congenital adrenal hyperplasia due to 21-hydroxylase deficiency, acute adrenal crisis is also a medical emergency, so initial management should be fluid resuscitation with IV bolus of isotonic saline, 20 ml per kg, and repeated bolus as necessary. Administering dextrose if the patient is hypoglycemic, and they must be rehydrated with fluid after the bolus dose to prevent hypoglycemia. A stress dose of hydrocortisone, 100 mg per meter square per day, are vital in the management and should be given as early as possible, concomitant with IV fluid treatment. Life-threatening hyperkalemia may require additional therapy with potassium-lowering resin, IV calcium, insulin, and bicarbonate to protect the heart. The goal of therapy is to reduce excessive androgen secretion by replacing the deficient hormones, and proper treatment prevents adrenal crisis and viralization along normal growth and development, normal pubertal development, sexual function, and fertility. The first one is glucocorticoid. Cortisol replacement with oral hydrocortisone in 3 divided doses of 10 to 20 mg per meter square per day. Patients with classic 21-hydroxylase deficiency requires long-term glucocorticoid treatment to inhibit excessive secretion of corticotropin-releasing hormone and adrenocorticotropin hormone and reduce the abnormally high serum concentration of adrenal androgens. Hydrocortisone is the treatment of choice because of its short half-life and the minimal growth suppressive effect. The efficacy of treatment is best assessed by monitoring ACTH, 70-hydroxyprogesterone, dihydropindasterone, and androstenedione. A target 70-hydroxyprogesterone range of 500 to 1000 nanogram per dl, though still higher than normal, helps to avoid the adverse effects of overtreatment. Children also should have annual bone age radiograph and a careful monitoring of linear growth. Older children and adolescents where growth is complete might be treated with prednisolone, 5 to 7.5 mg daily in 2 divided doses, or once a daily dexamethasone 0.25 to 0.5 mg, because those prednisolone and dexamethasone, they causes growth suppression than that of hydrocortisone. Hydrocortisone is more preferred because of its minimal growth suppressive effect than other corticosteroids. But after growth is completed, we can give prednisolone and dexamethasone. The other thing that should be given is mineralocorticoids. Infants born with salt-wasting form of 21-hydroxylase deficiency require replacement with mineralocorticoids. Fluorocortisone, usually 0.1 to 0.2 mg, but occasionally patients require up to 0.5 mg per day, and sodium chloride should be given. The sodium content of human milk or most infant formulas are about 8 milliequivalent per liter, and it is insufficient to compensate for sodium losses in these infants. Overtreatment causes Cushingoid appearance, central obesity, suppressed growth, loss of height, standard deviation for age, osteoporosis, insulin resistance, and impaired growth tolerance. So we should have to avoid overtreatment with hypercortisolism. Mineralocorticoid overtreatment can cause hypertension, whereas undertreatment with glucocorticoid causes adrenal crisis, increased adrenal androgen, accelerated bone age, precocious puberty, loss of growth potential, hirsutism, amenorrhea, and infertility. Whereas mineralocorticoid deficiency causes low BP, salt loss, fatigue, lack of energy, increased requirement for glucocorticoid replacement. So we should have to avoid overtreatment and undertreatment. We should have to follow them appropriately. Plasma renin activity levels might be used to monitor the effectiveness of mineralocorticoid and the sodium replacement. Hypotension, hyperkalemia, and elevated renin levels suggest the need to increase the dose, whereas hypertension, tachycardia, and suppressed renin levels are clinical signs of overtreatment. Excessive increase in fludrocortisone dosage also might retard the dose. Regarding surgical cares, infants with ambiguous genitalia require surgical evaluation and, if needed, plans for corrective surgery. Risks and the benefits of surgery should be fully discussed with parents of affected females. Significantly viralized females usually undergo surgery before 1 year of age with, if the receiver clitoromegaly, the clitoris reduced with partial excision of the corporal bodies and the preservation of the neurovascular bundle. Vaginoplasty and the correction of urogenital sinus usually are performed at the time of clitoral surgery, and the revision in adolescence is often necessary. When we see the prognosis, children who have congenital adrenal hyperplasia often are tall in early childhood, but due to early closure of the growth plate of the bone, ultimately they are short in adulthood. Recent data suggests that patients born with congenital adrenal hyperplasia due to 21-hydroxylase deficiency are about 10 cm shorter than their parental-based targets. Advanced bone age, central precocious puberty due to androgen excess causing early epiphyseal fusion are the primary factors. In addition, the treatment of congenital adrenal hyperplasia with glucocorticoids can suppress growth and diminish their final height. Bone density is reported to be normal in most patients, and the prevalence of metabolic abnormalities such as obesity, insulin resistance, dyslipidemia, the polycystic ovarian syndrome has been reported to be high due to the disease themselves or due to glucocorticoid treatment. The influence of prenatal sex steroid exposure on personality is controversial. More consistent evidence regarding the effects of androgen comes from gender display activities of young children. Most children with CH manifests normal neuropsychological development. Moreover, despite a tendency toward male gender role behavior and homoerotic fantasy, most girls with CH identify as females and exhibit a heterosexual preference. Both male and female patients are fertile but have reduced fertility rates, and this consequence is due to biological, psychological, social, and sexual factors. This is all about the most common type of congenital adrenal hyperplasia, 21-hydroxylase deficiency. Thank you for watching.